Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Kevin Spencer and Dr. Vikki DiGennaro from Agilon Health about embracing the future of advanced primary care. Let's get started. Oh, Dr. Dan, my goodness, it is so good to see you. How much I have missed you so much.
Absolutely. It's good to see you, Faisel. Looking forward to the conversation today.
This is actually our first conversation post ChenMed, both of us in our new careers, and we're a week into our new roles, and so I miss you even more. And I use a lot of Dr. Dan. Everybody knows already there's a bunch of Dr. Dan-isms about adult learning theory and introducing doubt to help influence positive behavior and all that stuff. So it's great to see you. And I'm so excited for our guests today, Dr. Spencer and Dr. DiGennaro. Thank you so much for joining us.
Yeah, thanks for having us.
As we look forward to the future of just value-based care, high-quality primary care, advanced primary care, we could start with Dr. Spencer. Like, what would you identify as some of the main levers for ensuring success in a high-quality primary care environment?
I think some of what you were referencing with Dr. Dan there on the learning of primary care physicians. I think the advanced primary care model in the future requires a different way of thinking about patient care, a population-based clinical pathway, earlier intervention, more prevention towards that. And the fee-for-service environment has not always lent itself, even though we may know those concepts, we didn't always live them. And so I think that's the one basis is what's our mindset and how are we approaching the issue? And then the drivers really are, clinical pathways, early intervention, appropriate right care at the right time, thorough documentation, to feed our engines that identify high-risk cohorts so that we can leverage the right intervention. So those are some of the things that are important going forward. And we'll probably talk later in the session, but I think creating a macro environment where there's sustainability and belief in sustainability so that we can invest and innovate is important.
So you mean like we can't just help everybody at one time? Like we'll meet with like operations people and they're like, okay, you got this population of people. Now, what are you going to do? Help everybody at one time? Like, there's only so much that we can do as clinical people. So you're right. Like with identifying those populations, like what are some of the strategies to help people? Still most of the country's primary care doctors are still working within the fee-for-service framework. Maybe like we've met doctors who are they're barely surviving on 2 to 4% margins as it is. What are some strategies that you could help with some of the doctors early on? Like, hey, these are the people that you really ought to start focusing on now.
Yeah, I mean, we're doing something that we've labeled active panel management, where we use our algorithm to identify our highest risk people. This is usually 8 to 10% of your population. And we're taking time out of the clinic and actually meeting and going through that list. This may be 20 to 40 patients per provider, but those are the 20 to 40 that are doing the worst, have the most morbidity, often are in and out of the hospital. And so again, back to leveraging people outside just the physician themselves, whether that's a care management team, a pharmacist, palliative care in the home, a renal team specific to CKD4 and worse. So by identifying those folks proactively, we're getting the resource towards them. So that's one of our big strategies is, again, the awareness of the physician of their overall panel. So at any one time, you should know what 25 to 50 people are you most worried about when they're not in front of you, when they're not in your office. And we've seen a lot of professional satisfaction from that. Like, physicians are feeling like, wow, I don't have to go it alone. We have brought resource back to the economic sustainability being so important. We're bringing resource to the market ahead of the outcome so that we can invest in these patients so that they can get better care and better outcomes. And so they feel not alone, knowing their care team is an RN, a social worker, and a pharmacist, and someone going to the home for their sickest of sick patients and getting better cancer education, getting better goals of care discussions to happen with the patients.
just the team alone, having that's a huge mindset shift for many doctors, especially in primary care doctors who are used to, they opened up shop. They may have one person up in the front. They may have one or two people up in the back. And it's like to think that they actually, with the flexibility that comes with having an actual team and leading a team of people to help drive that. You mentioned about people in and out of the hospitals, focusing on the patients who are going in and out of the hospitals. For some of the doctors who kind of feel like, like let's say they got 2,000, 2,500 patients, and it's like, hey, we need you to focus on the patients who are in and out of the emergency room. What would be some guidance that you can give to them when they may be feeling like, my gosh, what could I do to help influence a patient from avoiding the emergency room and coming to me instead?
I would say, I think it goes back to our health system in this country and the fact that it's not sustainable. It's not sustainable for patients. It's not sustainable for physicians. And so really how we have embraced value-based care in terms of the full risk model, at my practice, we're 60 physicians, 19 locations, and we are at full risk and have been since 2018 for over 21,000 patients. That gives us the ability. Yeah, we've been partnered with Agilon since 2018, and we've been very successful. We've shown improved outcomes for patients. We've shown decreased burnout and improved sustainability for physicians. And really, it's that full risk capability where you're able to identify the sickest patients and be able to provide the care to them that they need at that point in time, while also not having to worry about the financials of running the fee-for-service hamster wheel. Because when you're trying to see 30 patients a day just to keep your lights on, the last thing you can worry about is Mrs. Smith going to the emergency room. But when we take that out of it, now you have the time, the resources, the capabilities to provide better care for patients, and it's a win for the physician too.
What was it like early on when patients, there's a huge mindset shift when patients show up unscheduled in fee for service, like, versus in the value-based care world, like, please come on. Like, what was it like in the early days, especially?
At least for me, I'll let Dr. Kevin Spencer answer in a second, but at least for me, it was just training our physicians to understand that you want to see that patient. You want to say yes. Like in my practice, anyone who calls in, you're getting in the same day for that acute need because we're going to prevent you from going to the hospital. So it was a training. And as you show success stories over and over again, I think it just becomes a good cycle in that it continues to provide that higher level of care. But Dr. Spencer's worked with people around the country. I'm sure he could speak to that too.
I think a big piece of it is what we've been successful at is proactively scheduling. So there's a group, and I know at ChinMed they do this too, there's a group of patients that likely need to be seen every month, or sometimes maybe for a short period of time, even more frequently than that. And so who are those people? How do we talk to the patients about what we're delivering for them and why? Getting their input on what the outcomes are that they want to achieve and we want to achieve together. And that the evidence that seeing your primary care physician more often and being closer to them is what prevents that. Some of these things we're trained to pick up on that we see you worsening before you actually feel really bad. So that's one aspect. And I think when you proactively schedule those patients, you have less of the kind of catastrophic, acutely ill, overwhelming patient come into your building. But even if they do, you want them there, and we're training our patients, call us first. Please let us be involved in the decision of where to go get care. And what you said earlier is really important, which is how do physicians not feel overwhelmed when they look at their panel of sickest people and say, they went to the hospital, did I fail them? And the analogy I use is population health and total cost of care practice is a lot like soccer. It's not like basketball. You do not go down this court and shoot every time and score 50% of the time like you do in basketball. When you're managing a panel, you may review 20 patients, and actually there may only be 2 out of the 20 where doing something proactively would have impacted and prevented something. But if you do 2 out of 20 every month and prevent 2 admissions every month for one physician in their panel, we're writing the white paper about you. So, it's like soccer. You'll run 8 to 12 miles playing the game. You might get 1 shot on goal, but man, 1 goal can win the game. That's the mentality of the way you think about patients.
You know, Kevin, one of the things you mentioned is about those small improvements, incremental improvements in care can make such a big difference. If primary care was a drug and you could prove those outcomes of the drug, you'd be going to the FDA for approval, and then you'd want to charge $1,000 or $2,000 per month for that drug, right? It's amazing that we know the answer. It's been there forever. We're having a hard time as a society funding it correctly.
Yeah. And I think that, again, that goes back to, regulatory wise, we're participating in ACO Reach. And so that is set to expire in 2026. And what we really want to see is some variation of that to continue, because we have been able to provide fantastic care for patients. I have a patient in that program who, and again, in the normal fee for service schedule, you're just getting people in and out. She came in for a follow-up on her blood work, and she was very distraught and just kept talking about her computer. And in the real world, it was like, okay, I'm sorry, Mrs. Smith, good luck on your computer. But because I had time and resources, I really sat and talked to her, was able to send someone out to her home. It sounded like she was having trouble getting into her computer. So they helped her with that, which doesn't sound like a nursing issue. However, being in the home, my nurse noticed, hey, there's some things going on here. I think we need to investigate further. Was able to bring her back, do memory testing, diagnosed early dementia, got her on the right treatment, the right resources, the driving evaluation. And so this is a patient who would have crashed into healthcare down the way eventually. I don't know what would have happened, maybe literally crashed her car. And we were able to help her and intervene early. And I was only able to do that with the resources I have from that ACO Reach program. And so my hope is that we continue to invest in programs like that going forward, so we can continue to expand this and provide this excellent level of care.
And speaking of that, I mean, all of these models coming out of the Medicare Innovation Center, which are great, but is 3 years or 5 years really a long enough runway to see if these work? And when you staff up to run one of these models and then the model goes away, that's pretty frustrating for docs, right? I mean, it sounds like Agilon helps you smooth that out. I'm assuming that if ACO Reach were to go away, you would attempt to transition those patients to MA and they would still be able to be your patient. But isn't that frustrating when the models go away that quickly, rather than saying we're going to add more, or there's going to be an on-ramp and an off-ramp, not a starter pistol and somebody waving the checkered flag and we're done?
I think it's going to take like a model that you run for 10 years to really understand it, is what our view would be. And the other thing is, I think the model, we've learned what we needed to learn. The patients get better outcomes, physicians have less burnout and are better clinicians, and it saves the system money when the primary care physician is in a total cost of care model. At Agilon, we have 8 different ACO Reach models around the country, and we saved the trust fund about $25 million in the work that we're doing. So we don't want this to go away. And working in a total cost of care model on the Medicare Advantage side is something that we do, but we really are proud of being payer agnostic. If the patient feels like red, white, and blue Medicare is better for them, then that's what they should choose. And then we just need to take care of them in the same model. And what's nice is the clinical models that we work under in this model, we give to all patients. So, agnostic of payer. So yeah, we just really feel strongly that, the policymakers need to be thoughtful about making sure there is a full total cost of care model, whether that's tagged on to MSSP or continues as ACO Reach. But to me, at Agilon, what we don't do is do what many people did, which is try to dabble in value or incrementally get into value. We found that just flipping the switch and taking our providers 100% into an upside downside model is what changes the behavior of the physicians and, frankly, in turn, the patients. Is the way we take care of them, and the resources that we can bring to bear in that environment is having good outcomes.
It's incredible how the mindset of the patients, like you said, changes as well once they get exposed to this environment. And I recently, this past month, my own auntie had 3 congestive heart failure exacerbations back to back, like within a few months. And it was from, she was confusing shortness of breath from her asthma to shortness of breath from the CHF, using albuterol, overusing her albuterol, overdoing the breathing treatments, ending up in the hospital. Outside the care was not coordinated. And I had to end up going up to go visit her and meet with the doctors and try to coordinate everything for her. And then, so when I was up there, I asked her, I said, when was the last time you saw your primary care doctor? And she said, oh, I just saw the doctor not even a month ago. And I said, well, did you complain to the doctor about, hey, what happened? Like, why am I keep having to go back to the hospital when I haven't been to the hospital ever before? Like, this is a new thing. This is the third, this at that time was second. Like, why? And she said, well, the doctor's a very nice doctor. Poor doctor's so busy. And so she still has that mindset of the fee-for-service patient, that my doctor is a good doctor, very, very busy doctor, overwhelmed doctor. And then so on this last discharge, she went into a new practice that was a risk practice where the doctor takes full responsibility. And her husband called me and he said, I never thought of it that way, that we could be like this with our medical care and our health. Because he said, Faisel, I would never tolerate having to take my car to the mechanic when it gets broken down. I mean, if my car gave me a little bit of a trouble, I'd ask my mechanic, hey, I bring this thing in over here like every 5,000 or so miles. Like, why did this break down? Like, I hold my mechanic more accountable than we hold our doctors accountable. And it's amazing. You're right. Like, the mindset shifted, the expectations change, with the health outcomes, but also the relationship changes too. It's a beautiful thing. I would love to hear about, there's a lot of frustration. There's a lot of frustration right now, the medical debt being the number one cause of bankruptcy. So people are not happy with the medical system in general. We're hearing enough now. We're feeling the effects. We read about life expectancy going in the wrong way for the first time in America, right? And since we've been measuring this, where the rest of the world is moving forward with life expectancy. So we got a couple big variables out there that people are starting to feel, and we're starting to witness it and experience it in the clinical models. What has that experience been like for your doctors, where now the patients are like, primary care is a lot more than referral renewals and an annual wellness visit. I mean, primary care is healthcare.
I would say I think it's taking that ownership of it and realizing, so much, to your point that you just made, most of a patient's healthcare experience comes outside of that short visit that you have in the exam room with them. It's literally everything. It's their home, it's their family, their resources, their interaction with other specialists. And so I think it's changing that mindset, again, to your point, both to patients and to physicians, that we own that, is saying when that patient comes in for, I'm just going to get my referral back to cardiology, is that cardiology referral really necessary? Or have you been stable for the last 5 years and had a normal echo for the last 5 years, and you can just see me now and I will take care of that? Or, do we really need to do that invasive test for someone with advanced dementia that it's really not going to change outcomes? If anything, it's going to hinder their quality of life. So let me get you enrolled in the right program, our palliative program, where we're going to, really maintain your wishes. So it truly is a complete mind shift change. And I think that you have to be 100% into something Kevin said earlier. It's not like tiptoes. It's everything, because that is what the patient's experiencing. Think about it, what you would want for your family member. And I think it hits home for us when we experience it with our own family members.
I think Vikki and I both have lived on both sides of the world in regards to we've been leaders and CEOs of our practices as well as practicing physicians in the model. And I would say what doctors are looking for is stability, economic stability. There was a recent JAMA article that's talking about the threat of independent medicine in the current environment. So I think once a doctor feels stable, and then they know that they're responsible for the patient. So a lot of what you were saying, Faisel, around the patient's behavior changing is led by their physician. When I walk into a room and I'm thinking, how likely is this person in the next week or next month to go to the hospital? And that's front of mind in the way I'm going to engage them, instead of, am I going to click through my EMR and do some referrals and refill some medicines and medical legally protect me and my note, and that was my goal. That's no longer a goal. The goal really is to think through what that patient may need and intercept processes that may be going on and look at prevention. And when you talk to the patient that way, they're more likely to be on your team and have shared goals with you and call you before they make healthcare decisions. What Vikki's talking about, talking to a patient about no longer necessarily needing the cardiologist, takes much longer than walking out of the room and letting them see the cardiologist. So it's a physician behavior mindset around highest value for your patient.
Right. And primary care being, as a primary care physician, you may not know as much about the heart as the cardiologist, but chances are you know a lot more about your patient and all the other interactions that take place. Generally we throw around statistics, but almost all those statistics are based on one or two conditions. And now it's not at all uncommon to see somebody with 5 or 6 conditions. And honestly, those studies, for the most part, aren't done. So now we're just having to guess. I don't get guess is a bad word. We're having to use our best professional opinion, as one of my neurology professors in medical school said. He didn't like it when I said guess. It was my best professional opinion. But our best professional opinion with somebody with 7 medical conditions winds up being a guess, right?
Yeah, and how many of those conditions are maybe polypharmacy? I think that's the other piece of this. Or same with someone goes home from the hospital and they have no idea what they're supposed to take. And so many readmissions we see are because of medication errors. So we've made a priority that our highest risk patients are seen within 48 hours of discharge. And so even if that patient is too sick or frail to come into the office, we have a provider that we're sending out to them. Because again, you can do as much damage as a condition sometimes, if not more, with mismanagement of medications for patients.
Right, and they've had a supply from their insurance company that's been coming in the mail, and they go in the hospital, and now the hospital gives them drugs, but they're generic, so they look completely different than what they have at home. And we all have somebody come in and say, yeah, it's that little green pill, and I have no idea what little green pill they're talking about unless they have the bottle in front of them with them. So that makes it difficult. And I've heard it said that the best med reconciliation is at the patient's kitchen table. So I wonder if you actually get better results sending somebody out than when they come into the office. I don't know if you've studied that, but that would be an interesting study if you haven't.
We'll put it on the list.
We do it for some of our patients. I don't know that we've done the study, but I think we hear lots of anecdotal stories, just like we were sharing earlier, of what Vikki's nurse found when you go into the home, into the patient's environment. The other thing that I think is important that Vikki does really well at her practice is how are you actually structurally running the operations of your practice to achieve the goals? So the reason she can see all those patients within 48 hours is because they save appointments and have those appointments in the schedule saved that they can be released for a same-day appointment. They have outbound callers getting the sickest people at the front of the line to see the doctor. That's the other part I've enjoyed about the virtuous nature of taking care of the Medicare population in a full risk environment. The oldest, sickest, most infirmed, and most vulnerable patients in our society historically were being shunned by some physicians because of economics in the fee-for-service world. And now they're at the front of the line, and they're our most cherished patients, not because of any economic reason. They're the ones we train for. They're the ones who need us. And now we're able to identify them and help. So that's another part of this model that's just so virtuous. It's like we will not be successful if we are not able to care for them in a valuable way.
Yeah, it aligns incentives. My analogy that I'm playing with right now on that is every doctor comes into the office every morning with an airplane with 20 or 25 seats, and you've got to decide who gets to pre-board, who gets first class, who gets business class. I mean, you want to go there safely. The plane needs to get there safely. Everybody needs to get there, but you need to have the extra seats available. And rather than just be the person who can pay the most for those better seats, it's the people who need it the most, the high-risk patients just getting discharged from the hospital.
I absolutely love that analogy, Dr. Dan. Am I allowed to steal that?
Absolutely.
I'll pay you. I'll pay you.
Absolutely.
That's great.
We call those Dr. Danisms. I mean, they're becoming very popular.
I've got a question for you. I mean, we just at ChenMed certainly we're seeing the impact of the rate change, the V24 to V28 rate change. And when you're doing this good work, taking care of the neediest patients, and then all of a sudden an impact goes into place like that cuts revenue. What do you all think about that? How is that impacting you, and how do you approach those changes like that?
You want to go first, or?
Yeah, it's not ideal. I think that when Kevin spoke earlier, it's all about stability for us. I mean, you think about these codes, and it's not just a dollar association. It's also a way that we identify patients for the programs that we are running. Using the right algorithms, that code might indicate that a patient's high risk. So to the point about like more resources, more touch points, or, that patient would be appropriate for our renal program or our palliative program. So I think ultimately, I'm not an expert on how they make these decisions. I guess from a practicing PCP perspective, I would just ask that, more stability and to kind of be aware of what I should be focusing on and how to do that. In our practice, I think at the end of the day, because we really are caring about the patients first, like in my opinion, everything I do is to support that patient and that patient-physician relationship. Like we'll figure it out. Like it's not going to change what I do for the patient. It would be nice if I had the resources to support that, but it's really not changing our care of the patient. I just would ask for more stability.
I think we expect, and frankly, it's their job to look at the programs and look at Medicare and make appropriate changes. I would just say, to Vikki's point, when you lower the rate that suddenly and that fast, because then it's not only V28, there's also lowering of the rate. There's been other financial pressures that they, with a stroke of a pen, Congress put into effect. And what you're seeing is some unintended consequences, I think. Walmart's left the primary care space. Walgreens has left the space. People don't want in the space as much anymore. They've made Medicare Advantage much more difficult. And so there's going to be less benefits given to patient, we predict, in 2025 as a result of that. So yes, we need to be appropriately regulated, and we need to study this with wisdom and get physicians' opinions who are doing and living this to do that. I know Agilon spends a lot of time on Capitol Hill trying to illuminate, the truth and what really is happening. I mean, the effects, the short answer is our margins are less, and it's been more difficult, and we're able to invest less ahead of the outcome of the patient right now in the current environment. But we're hopeful. We know that they're watching, and they've seen what's happening, and with the stroke of a pen, they can ease some of this and make it a fair, healthy environment to run a stable business over time. And that's what I would want them to hear from responsible physicians who care a lot about their communities is, we just want it to be stable. The sudden changes that change it that much, that suddenly, are really difficult to endure. Thankfully, our model has worked okay, even in this environment, but that's not been true for everyone else.
I agree with you, especially with the closing about the policy change, these quick policy changes. I think enough understand the need to transition to a relationship-based healthcare delivery system. We got to move away from the transactional relationship and more towards these holistic doctor-patient relationship, doctor-doctor relationship, doctor-team relationship. I hope that anyone who's listening, who can help influence, especially with policy, is that, hey, I think enough of us agree that we got to move towards this value-based.
Faisel.
Yeah.
We're sort of in a nadir here. I would love for Vikki to give us a positive patient story before we completely wrap up here, so we end on a positive note instead of a negative note.
Yeah, sure. So again, I just talked about those programs, and I think this highlights those programs. So I have a patient who has CKD4, and so we were watching her really closely. She was in our renal program and was starting to progress to CKD5, and so we really had to make a decision as to, is this patient going to be on dialysis or what's our next step? And just given her whole picture, it really wasn't what she wanted. It wasn't the right thing for her to go into dialysis. And this is someone who easily could have been swayed, like one hospital admission, put in the line, do the whole thing. Since we had this relationship and this program and this whole support team, we actually transitioned her into our palliative program, which eventually transitioned her into hospice. And so that sounds great. And you think, okay, better quality of life. The point that I find interesting is I keep tabs on her, and that was over a year ago. And so we know that hospice, you're really thinking it's someone in the last 6 months of life. We don't just kick them off at the end of 6 months. The point to me was that we have provided her the quality of care that she wanted. We did not do harm to her by all the things that could have happened with her complications with dialysis. And she's actually living longer and a better life for it. And so at the end of the day, that's the kind of thing that makes me sleep well at night and excited about the future, is that it's not just this transactional relationship. Like, you build these bonds and you help guide people to the, true path that they want to take in their life. So that to me is really inspirational.
Thank you so much. It's perspective like this that can help us advance the goals of value-based care. Thank you so much.
Thanks, guys. Thanks for having us.
What are your thoughts on embracing the future of advanced primary care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.